Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're talking about bronchiolitis and its typical culprit, RSV, or respiratory syncytial virus. As always, let's kick things off with our practice question. The nurse is reinforcing education to the parents of a toddler who has been diagnosed with bronchiolitis. The nurse informs the parents which of the following is the most likely cause. Is it the Haemophilus influenzae type B, adenovirus, the respiratory syncytial virus, or rhinovirus? All right, so let's talk about bronchiolitis. It is one of the most common reasons that infants and toddlers land in the hospital during that yucky respiratory season. The virus that is usually behind it is respiratory syncytial virus, or RSV. And I'm quite sure if you have kids or if you work with kids, you have heard of RSV by now. But what I want to start with is really understanding bronchiolitis, which means we need to zoom in on the bronchioles. Remember, we have the bronchi, our big tree trunks of our airways, and those branch off into the tiniest little branches of the airway tree. Those are the bronchioles, kind of like the twigs at the end of the tree branch. Their job is to carry air down into the alveoli. Remember, that's the grape-like little sac, for lack of a better word, where oxygen and carbon dioxide are exchanged. So we need our bronchiole to bring that air into the alveoli so we can have gas exchange. In healthy lungs, air flows really smoothly through these bronchioles. But when RSV gets in there, it is not good. RSV is a virus, respiratory syncytial virus, that just loves to infect the cells in the bronchioles, specifically the lining of the bronchioles. It takes hold and causes those tiny passageways to get inflamed, swollen, and clogged with thick mucus. So that nice clear airway is now all clogged up, and it's really hard to move air through. The two big problems that come with this inflammation and mucus plugging are the obstruction of airflow and air trapping. Babies and toddlers especially are very vulnerable to this because their airways are already teeny tiny. So even a small amount of swelling and extra boogers in there can narrow their bronchioles and really cause them to be too narrow for air to go in and out. That's what leads to kids with bronchiolitis developing wheezing, retractions, nasal flaring, and that belly breathing. They're working extra hard just to get air past those clogged little bronchioles. And of course, where do the bronchioles lead to? The alveoli, where we are supposed to get gas exchange. So when mucus is plugging up those bronchioles, some alveoli don't get fresh air, which causes that poor ventilation perfusion match. We're not able to have good gas exchange, right? Oxygen can't get into the blood and carbon dioxide can't get out of the lungs. So that's going to lead to a lot of our signs and symptoms where we have like hypoxemia, low oxygen saturations. It's all about that gas exchange not happening because the bronchioles are clogged up. Now, it's really important to note that many viruses can cause bronchiolitis, all right? It could be adenovirus. It could be rhinovirus. Kids get rhino all the time. But the most common culprit, that virus that just loves the bronchioles, is RSV. So if you see a test, a question on the NCLEX, whatever, and you see bronchiolitis, your brain should jump to RSV. And just like the flu, RSV has a season. Late fall through early spring is when the peds floors are full of wheezing, retracting little ones, needing oxygen support, because RSV got down into their bronchioles, caused inflammation, and you know the rest. I have taken care of a ton of babies with RSV. I used to joke that my time in the PICU during that, winter, early spring season, I was like a professional booger getter because we really just had to clear out the airways of these tiny little infants and toddlers who had RSV, bronchiolitis, and needed some support. They often ended up with me in the PICU because the amount of oxygen they needed in that high flow nasal cannula would go past 4 liters. And that was kind of the threshold for what we would allow on our floor versus the ICU. So one of the particular stories that jumps out, though there were many very similar to this, I believe this kiddo was about 9 months old, and he was a totally previously healthy infant. He was not immunocompromised. He was up to date on his vaccines. He really had never been super sick before. He had definitely never been hospitalized. So the story that I'm getting him on a night shift. So I'm, reading through his chart. He had been admitted 1 day prior. This was my first of like 4 nights in a row. And the story was, hey, this started out as like a runny nose, a mild cough 3-4 days ago. But then we noticed he was breathing funny. That's a phrase that should really make you think twice when a mom says her kiddo is breathing funny. So what she was seeing was retractions. He was breathing really hard, trying to suck air in, and those muscles were working extra hard. She was very smart to be scared by this and take him into I think she went initially to urgent care. They saw him retracting and they sent him over to the ED. But by the time I met him in the ICU, he had already been placed on high flow nasal cannula the day prior. And we were starting to, get him stabilized. But here's the thing, when we're talking about interventions for this is a virus. We can't give antibiotics. That's not going to do anything for RSV. A lot of our care, even in the ICU, is supportive care. It's helping them ride this virus out so that their body can recover. So anywho, back to our story. I get the reports. It's pretty standard. I go in to do my assessment. He has some mild nasal flaring and I would say mild retractions at this point. He's in mom's arms. He's on the high flow nasal cannula. He's a little pale and I can definitely hear wheezing, like really intense wheezing as soon as I auscultate his lungs. And remember, why is the wheezing happening here? He has RSV. That has inflamed his bronchioles, those tiny little airways. They're clogged up with mucus. And, for an adult, that would be annoying. But for a baby whose airways are already really small, swelling plus mucus equals major obstruction. So this baby's having trouble getting air in and out. That causes the wheezing. That causes the retracting, okay? So what I need to do is help clear his airways out, all right? They're not able to eat very well when they're working this hard to breathe. So we did have him on IV fluids. We're supporting his breathing with that high flow nasal cannula, giving humidified oxygen. And then we're working on clearing out that mucus. So we'll often do nebulizers with normal-saline to loosen everything up, and then suction, suction, suction. We'll do some chest physiotherapy or CPT, where we pat on their little back, on their little chest, literally trying to break the mucus up. Suction, suction, suction. We especially want to do this before the baby feeds if their breathing is in a place where we're comfortable with them feeding. For at least my first night shift with this kiddo, he was working too hard to breathe for us to be comfortable with him PO feeding. And if we're on high flow nasal cannula, we're not going to be blowing that air into their lungs and also feeding. Because what does that sound like? A risk for? Major aspiration risk. We don't want to mess around with that, right? So that's why he's on the IV fluids for this short term. If it ends up going much longer, we'll have to talk about parenteral nutrition. But right now, we're not worried about that. This is the first day he's in the hospital. We're getting him some fluids. We're getting him some oxygen to ease that work of breathing. And we are clearing out those lungs. So nebulizers, chest physiotherapy, suction, suction, suction. This is what I mean by my job during RSV season is to go get boogers. We are literally just clearing mucus out, trying to open up those airways. That makes it easier for air to get in and out. They breathe easier. Their work of breathing goes down. They start to get better. So what I'm trying to get at, meds are not the star of the show here. In our last episode, we talked about asthma. And oh my gosh, we gave that kiddo so many different meds between his LABA, his SABA, his mag sulfates, the earprotropium, the steroids. We're not doing none of that when it's bronchiolitis caused by RSV. We are literally just doing supportive care to help keep this baby from working too hard to breathe. That's what the high flow is doing, and trying to clear out those airways. So oxygen, suctioning, hydration, keep him comfy. Of course, we want him on the monitor, continuous pulse ox. We're keeping a close eye. Really, your assessment of his work of breathing is the most important thing. We want to see that work of breathing go down and then start to wean down that support. By support, I mean the high flow nasal cannula, how much support we are giving his lungs. So let's say, I'm forgetting exactly what it was at. It must have been at least 8 liters. We back it off to 7, then to 6. We gradually go down on how much flow we are giving this baby, and we watch his work of breathing. Do his O2 sats dip down? If so, we got to turn it back up. We watch all of that and let his body ride it out. We just support him while he's going through this virus. Now, one thing to note with RSV, it is typically worst on day 5. Day 5, around about, is when the virus is its most nasty. Okay, it can take up to 2 weeks afterwards for them to start getting better, but usually after that day 5 is when we, turn a corner and we start to see major improvement, even if they're not all the way back to normal. So if I remember right, I had this kiddo 3 nights in a row, and then he went home the next day. So he was in the hospital for about 4 to 5 days before we could get him weaned off the high flow, and he was safe to go home and had a decreased respiratory effort. He just needed that supportive care before his body could get rid of that nasty RSV virus and turn the corner. So your big takeaway here with bronchiolitis, symptoms come back to the airway. Our tiny little bronchioles get swollen and plugged up. That airflow is obstructed, so we can't have gas exchange. And that's what leads to that oxygen going down, that work of breathing going up. Your main interventions are supportive. Keep that airway clear. Support them with oxygenation, hydration, monitor closely, and help them ride this virus out. So with that being said, I'm going to circle back to our practice question, and I know you guys are going to get this one right. The nurse is reinforcing education to the parents of a toddler diagnosed with bronchiolitis. The nurse informs the parents that which one is the most likely cause of bronchiolitis. Is it Haemophilus influenzae type B, adenovirus, respiratory syncytial virus, or rhinovirus? What do we have? And I know you guys all know it. Say it out loud with me. It's C, respiratory syncytial virus, RSV. I hope after listening to this episode, you have a little bit of an idea of what to do with bronchiolitis, the supportive care, etc. But what I really hope is that when you hear bronchiolitis, you think of that culprit, RSV, respiratory syncytial virus. I promise if you take care of kiddos or have kiddos of your own, you will see it at some point. So remember, no antibiotics, it's a virus. Supportive care, help keep those airways open, and it typically gets worse. About day 5 is the worst point, and then they turn a corner. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.